Good evening, folks. Okay, today's is a narrative discussing how multi morbidity brings seniors to the emergency department for care, regardless the reason. Okay, so I'm going to go through the presentation I made for you. Please enjoy. One second, please. Multi-morbidity continuity and the emergency department. The emergency department is not where older adults expect to spend their final decades. Yet it has become one of the most common destinations in the geography of aging. It is the place that they arrive when symptoms escalate, when fear overwhelms judgment, when caregivers are exhausted, when outpatient medicine is inaccessible, or when the system simply has no other door open. The emergency department is where older adults go when everything else has failed. Not only their bodies, the structures meant to hold them. I've watched this pattern unfold for years, first at the bedside and later from the vantage point of health system leadership. The faces change, the diagnoses vary, but the underlying story remains the same. Older adults living with dense clusters of chronic disease layered with depression, anxiety, or cognitive decline, cycling through the emergency department in a rhythm that feels both predictable and heartbreaking. Their visits are rarely about a single symptom, they are about cumulative weight of multimorbidity. And the absence of a steady hand to guide them through it. The patient who arrives before dawn, Miss K, was one of those patients. 83, widowed, living alone in a small apartment with a view of the river. She no longer had the energy to visit. Her chart read like a textbook of chronic disease, heart failure, diabetes, COPD, osteoarthritis, but the line that mattered most was the one blurred halfway down. Major depressive reoccurrent. Major depressive disorder reoccurrent. She came to the emergency department 5 times in 3 months. Each visit was triggered by a different physical complaint: shortness of breath, dizziness, chest tightness, not just feeling right, but the real trigger was loneliness and fear and the slow erosion of her confidence in her own body. When psychiatric distress intertwines with physical illness, symptoms become louder, sharper, more urgent. A flutter becomes a crisis. A headache becomes a stroke. Seniors like Miss K live in a state of heightened vigilance, scanning their bodies for danger without the internal or external reassurance that would allow them to wait until morning. Multi-morbidity creates complexity. Psychiatric symptoms create instability. Together they create emergency department dependence. The autonomy of multi-morbidity. Multi-morbidity is not simply the coexistence of multiple diseases. It is the way those diseases interact, amplify, and distort one another. It is the way diabetes complicates heart failure, how COPD complicates anxiety, how chronic pain complicates sleep, how depression complicates everything. Older adults with multi-morbidity often live in a state of psychological fragility. Their bodies do not respond to stress the way younger bodies do. A mild infection can destabilize heart failure. A missed dose of medication can trigger a cascade of symptoms. A night of poor sleep can worsen pain, cognition, and mood. But multimorbidity is also a social condition. It requires coordination across multiple specialists, multiple medications, multiple appointments, multiple instructions. It requires a caregiver who can interpret symptoms, manage the logistics, and advocate for the patient. It requires primary care clinician who sees the whole picture. Without the scaffolding, multimorbidity becomes unmanageable. And when it becomes unmanageable, the emergency department becomes inevitable. Psychiatric distress as emergency amplifier. Psychiatric symptoms, depression, anxiety, cognitive impairment, do not merely coexist with physical illness. They shape how seniors interpret their symptoms. And how they seek help. Depression dulls motivation and energy, making self-management harder. Anxiety magnifies bodily sensations, turning minor symptoms into perceived emergencies. Cognitive impairment disrupts medication adherence, appointment scheduling, and symptom recognition. Psychiatric distress is not a footnote in multimorbidity, it's a force multiplier. It is the reason a senior with mild chest discomfort calls 911 instead of waiting till morning. It is the reason a senior with dizziness goes to the emergency department instead of calling their clinician. It is the reason a senior with shortness of breath panics even with their oxygen saturation is normal. Psychiatric distress destabilizes the entire care trajectory, and when combined with morbidity, it creates a pattern of repeated emergency department use that feels less like choice and more like inevitability. Continue, continuity of care, the missing anchor. Continuity of care is supposed to be the counterweight, the stabilizing force that keeps older adults tethered to outpatient medicine. But continuity is fragile. Miss K's primary care physician retired. The new clinician was kind but overwhelmed, booked out for weeks, and unfamiliar with her history. The relationship never had a time to become a real relationship. Without continuity, every symptom felt like a question with no one to answer it. Continuity is not just about access, it is about trust. It is about having someone who knows your baseline, your fears, your patterns, you can tell, someone who can tell you this is okay, or let's adjust your medications, or come in tomorrow morning. Without that voice, the emergency department becomes the default. Continuity is the difference between a senior who waits until morning and a senior who calls 911 at midnight. The emergency department as a systematic mirror. The emergency department is not built for continuity, It is built for immediacy. It is built for the urgent, the catastrophic, the unexpected. But multimorbidity is not. Unexpected. Psychiatric distress is not unexpected. The crises that bring seniors to the emergency department are often predictable, not because they are dramatic, but because they are not the natural consequence of fragmented care. The emergency department becomes a minor, reflecting a mirror, reflecting the failures of the system upstream. Integrated behavioral health, team based primary care, transitional care programs, caregiver support, proactive outreach, home based care. When seniors arrive in the emergency department, they are not simply seeking medical evaluation, they are seeking reassurance, clarity, safety, and connection. Things the emergency department can provide only temporarily. The turning point. Miss K eventually enrolled in a home based primary care program. A nurse practitioner visited her every 2 weeks. A social worker helped her reconnect with her church community. Her depressive symptoms softened. Her confidence grew. Her emergency department visits stopped. What changed was not her disease burden, it was her continuity. Her multimorbidity remained, her psychiatric symptoms remained, but she had a team, she had a plan, and she had someone to call. She had someone who knew her. Continuity did not cure her illnesses. It stabilized her life. The system we need, reducing emergency department reliance among seniors, redesigning the system around the realities of aging. Multimorbidity is the norm, not the exception. Psychiatric distress is inseparable from physical illness. Continuity of care is not a luxury, it's a clinical intervention. Emergency department use is a symptom of upstream failure. A system built for aging must be relational, integrated, proactive, and home anchored. It must treat continuity as as in 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 infraction or not happenstance. It must recognize that the most powerful intervention for reducing emergency department visits may not be a medication or a diagnostic test, but a relationship. The space between crises. In the end, the story of multi-morbidity and continuity is a story about relationships, their presence, their absence, and the consequences that follow. Multi-morbidity may be inevitable, but or say psychiatric distress may be treatable but persistent. But continuity of care is something we can build, and when we do, the space between crises grows wider, calmer, and more humane. Okay, guys, that is A for you. I will be back on with B shortly.